congenital hypothyroidism, which is extremely important from clinical perspective, not only from pediatric endocrinology, but also from a pediatrician perspective. So what is the most common feature of congenital hypothyroidism, Dr. Sandeep? Yes. Mm-hmm. So if you have 100 children who have congenital hypothyroidism, what is the most common feature to all of them? Okay. So at 2 weeks, what will be the most common feature, Nimisha? No feature. So that is the biggest message. So if one message comes out of this is that every newborn needs to be screened, because the best of pediatric endocrinologists can identify 10% at birth. And the time which is crucial is 2 weeks. That's when you want to diagnose. It's very, very unlikely to be identified from that perspective. So we need to have a clear-cut understanding of universal screening, which becomes important. So what we'll do is that we'll talk a bit about pathophysiology, then the various causes. A lot of time will be devoted on how do we screen in normal and preterm individuals, and then we will carry forward in terms of management and Q&A at the end of it. So it's part of our MedEClasses lecture series. And so we have now started on thyroid. We have already had series with regards to the various aspects of growth, electrolyte, calcium, obesity. So a lot of it has been done, including the pubertal disorders. So we are focusing now in terms of the thyroid in that regards. So why is thyroid important? Because we can often have confusion in the beginning. So we had this 20-year-old girl with TSH of 28, which was referred for evaluation. Now, there has been a lot of talk about that in terms of what should be done. But what we need to remember here is that this was too early a time to do a TSH. So this clearly was an unnecessary workup at this point of time. And what we could have done is just to repeat it, and it was found to be normal. On the other hand, we may have the missing of cases also. So this is a 32-week-old neonate on routine screening, had TSH of 7, normal, free T4, was advised, okay, everything is fine, no need to worry about that. But what really happened in this case was that at day 14, we found that the TSH rose. So what we need to understand is that on one hand, we don't want to do unnecessary or too early workup. We also don't want to miss on these scenarios. There is a missing or messing which happens with congenital hypothyroidism, and this is what we're going to cover in that regards. All of you can go and have a look at our website, learning.growsociety.in, which has a lot of resources related to pediatric endocrinology. There are YouTube resources, including this lecture series. I think there are over 100 videos which are there, which you can have a look at it. Our website provides comprehensive tools and courses related to pediatric endocrinology, including a 2-year fellowship program and a pediatric endocrinology for postgraduate program, which is relevant for various postgraduates across the region. We do run a number of brand rounds, journal clubs, and PG lecture series, so you can all enroll. They are all complimentary in that regards. Our publications include the protocols, the basic and the advanced pediatric endocrinology, and our mobile application will help you guide in terms of day-to-day point of care management from that perspective. So today we are focusing on congenital hypothyroidism. So if we talk about congenital hypothyroidism, most of them are primary hypothyroidism. 1 in 3,000, they have high levels of TSH, including dysgenesis, which is by far the most common cause, and dyshomogenesis. Now, this prevalence, as we are screening, we are picking up more common cases. So if you look at GDM, people used to say GDM is less common, but when screening was started, many of the minor cases come up. So it's the same thing is happening. In India, the prevalence may go up to even 1 in 1,500 to 1 in 2,000 in certain studies, which is there. Secondary causes are extremely rare. So I think it will be like 10% of all causes. So 1 in 21,000. Now, most cases, we have always been told, are because of a multiple pituitary hormone deficiency. Rarely you may have a TRH receptor defect, a TSH beta defect, or IGFS1, which we'll not talk much. Most of them will have a multiple pituitary hormone deficiency, which occurs as part of somebody who has got micropenis, midline defect, hypoglycemia, and other scenarios. These people will be picked up because of these abnormalities, and you will be able to identify them. Thyroid hormone resistance is extremely uncommon, may occur because of thyroid receptor problem or a MCT8 problem or a problem in the monodeiodinase activity. So you're not able to convert your T4 to T3. So either T4 is not getting to T3 is not going into the cells, or the T3 is not acting. This is quite rare, 1 in 40,000. You will have a high TSH, high T4. So it's an unusual scenario, and therein comes the importance of T3. So this is one scenario where T3 will be a better predictor. So you have low T3.
Congenital hypothyroidism, there are 30% cases are transient in which we have iodine deficiency or excess. There can be maternal TSH receptor blocking antibodies which crosses the placenta. Maternal treatment with amiodarone. Prematurity is a very important cause. And again, in transient, we have dual oxidase defects. In 70% cases which are permanent, we have importantly primary, secondary, and at the level of receptor, that means impaired action. In primary, we have dysgenesis, which accounts for around 85%, and dysharmoniogenesis, which accounts for around 15%. In dysgenesis, the most important is ectopic, around 70% of the cases. Then we have athyrosis, which is aplasia, then hypoplasia, hemiagenesis. These are usually due to some genetic defects like PAX8, NKX2, FOXY1, or it can be due to de novo mutation. In dysharmoniogenesis, there is defect in the thyroid hormone synthesis, which accounts for around 15% of the cases. And the defect can be at the level of sodium iodine importer, can be at the level of TPO, TSS receptor, pendrin, deiodinase, or thyroglobulin. These usually present with goiter, and it is autosomal recessive, and the chances of recurrence will be 25%. We have in central week, it can be MPSD or it can be isolated. MPSD is usually can be due to genetic defects or malformations, and the most important are HSX1, septoptic dysplasia, LSX34, POW1F1, and PROP1. In isolated, we have TSS beta, we have TRH receptor defect, we have ICSF1 defect, and very less common causes due to impaired action, which can be due to MCT8 defect, can be due to thyroid hormone receptor defect, and or can be due to impaired conversion, increased consumption due to hemangioma. Now, transient hypothyroxemia prematurity, sir has discussed it in detail. As we discussed, in fetus, it is a relatively hypothyroid state, and there is the predominance of DIO3, and after birth, it changes to DIO1. So if you're screening early, like if you're screening a preterm, it's like screening in fetus. So they will have usually low T3, low T4, and low or normal TSH. It is an adaptive response. And the sick babies, if they are on treatment like dopamine for as a vasopressor, or they are on steroids, the TSH will further go down. So it will give a picture like central hypothyroidism. And in these cases, there will be a low T3, low T4, and TSH can be normal. Treatment is not recommended. It's unclear and can be detrimental as well. And free ectopher in such scenarios is unreliable, specifically the analog assays. And subsequently, they will have a delayed rise. We should rescreen them at 2 to 4 weeks after birth. And we should treat them if the TSH is more than 10, or if true T4, that is due with equilibrium dialysis is low, or they have features of MPSD. Iodine excess. In iodine excess, in fetus, in neonates, they will have a prolonged effect, and this excess iodine will lead to blockage of the TSH receptor. There will be a blockage of NIS1. There will be defect in the organification. So they will have a prolonged action. It is usually due to maternal iodine, due to antiseptics, or maternal drugs like amiodarone or contrast use. They will have a delayed rise of TSH, and there will be reduced uptake on the scan. And if it is persisting for more than 2 weeks, then we should treat with thyroxine. Maternal trap antibodies, as already discussed, placenta is like a sieve. Most of the hormones and nutrients crosses it, but in case of thyroid axis, TSH is prevented from crossing. T3, T4 crosses, TSH receptor blocking antibodies crosses, and antithyroid drug causes. So in TSH receptor blocking antibodies, it will cross the placenta, it will block the thyroid TSH activity, and it will present with congenital hypothyroidism. It is the apparent athyrosis. That means in nuclear scan, we will not see any gland, but on ultrasound, there will be a utopic gland. There is chances of recurrence in next pregnancy, depends on the levels in mother during that time. And since the half-life of TSH receptor blocking antibodies is 2 to 3 weeks, the effect may last up to 3 to 6 months. Isolated thyroidopenia. In this scenario, the T4 will be free T4 will be normal, and TSH will vary from 6 to 20. The causes, the most common being hemiagenesis, mild synthetic defects, a PHP can also present in such scenarios, non-thyroidal illness specifically during the recovery phase. In such cases, if the TSH is more than 6 after 3 weeks, then we should start treatment. And very close follow-up is required, because such cases they will have increased when there is increased requirement in the body, like during puberty or pregnancy, there are chances of recurrence of hypothyroidism. So close follow-up is required. Ectopic thyroid, as already discussed, thyroid gland descends from pharyngeal floor to the neck, and if there is any defect in this descent, it can lead to ectopic thyroid. And in such scenarios, we will not see any thyroid gland on ultrasound. We have to thoroughly examine the oral cavity to look for lingual thyroid. It is usually migration defect, and the thyroid is whatsoever thyroid gland is there, it is functioning normally. There are no lateral lobes, and the thyroid gland is having a preserved TSH effect. It's a permanent one, so we should be very careful that whatsoever gland is there, it is the only thyroid, and if it is been removed, it will lead to a hypothyroid state. They usually have a stable profile, but if they have hypothyroidism, we have to treat them. True athyrosis, in this scenario, there will be no thyroid gland, there will be no uptake on the scan, there will be no gland visible on the ultrasound. They are usually associated with some heart diseases like VSD and ASD. Routine echo is not recommended, but we should clinically screen them for heart diseases. So no gland will be seen on ultrasound, and no gland, there will be no uptake on the scan, and thyroglobulin levels will be low. Hemiagenesis, in which there will be a half gland is seen on one side and no gland on the other side. It is a developmental defect and can be associated with DiGeorge syndrome. It is a cause of isolated hyperthyroidopenia. When there is increased demand on the body, like puberty, pregnancy, this patient will have hypothyroidism, so we should screen them frequently. Apparent athyrosis. In this scenario, the nuclear scan will show no gland, but the ultrasound will show a thyroid gland. So when this will happen, there are three scenarios, like when the TSH receptor is now TSH receptor defect is there, or sodium iodide symptomatic defect is there, or externally the maternal TSH receptor antibodies are blocking the TSH. So no gland will be seen on scan, and ultrasound will pick up a gland. Out of this, the sodium iodide symptomatic defect and TSH receptor defect are permanent, and TRAB1 are transient. They have a detectable thyroglobulin levels. Dysharmoniogenesis, again a very important cause. It is autosomal recessive, so 25% chances of recurrence are there. There are many defect can be at many levels, like sodium iodide symptomatic, pendrin gene defect, TPO defect, dual oxidase defect, thyroglobulin defect deficiency, deiodinase deficiency, or there can be defect at the TSH receptor. There will be an increased uptake of nuclear scan except for the NIS and TSH receptor. Thyroglobulin level will be increased except for thyroglobulin deficiency, and usually they will have a goiter. So it is a common cause, and the course can be fluctuating. Some mild cases can be missed at birth, and they can present usually when there is increased demand. The genetic causes, NIS defect, presents as a apparent athyrosis, and is a very severe one. Pendrit syndrome, they have mild hypothyroidism and they have deafness. So hearing screening is very much important for all thyroid cases. TPO, it's a severe disease. There is increased thyroglobulin levels and there will be a perchlorate discharge. Dual oxidase, cause of transient hypothyroidism. Thyroglobulin deficiency, there will be low thyroglobulin and there will be increased uptake on scan. Dehalogenase deficiency, it is a variable hypothyroidism with spontaneous discharge will be seen. As already discussed, genetically, central hypothyroidism can be due to MPHD, or there can be isolated defect. In MPHD, we have HSX1. It's very important cause of septoplic dysplasia, and there will be a defect in the anterior and posterior pituitary. LHX1, LHX3 and 4, they have spine defects, and apart from that, PROP1, POW1, F1, they will have anterior pituitary defects. And in isolated one, we have TSS beta defect, we have IGSF1 defect, and there can be defect at the TRS receptor. So we should screen for features of MPHD. Conjunctive hypothyroidism is an important entity in which there is increased activity of DIO3. DIO3 will convert the T4 to reverse T3, so there will be more consumption. So in hemangiomas, there is more DIO3, which will lead to increased thyroid requirement. Body is not able to use that T4 T3. That is, it is getting converted to reverse T3. So by feedback mechanism, the body will create more and more TSH. The thyroid gland will be normal, and there will be a high reverse T3 levels. It is early onset, and treatment is usually with a high dose of thyroxine.
What else can you use there?
We can use, sir, L3, T3 we can use, sir. Thyroid receptor defect. It is usually defect in the TRH beta. It is 1 in 40,000, the resistance causes. It is severe and homozygous. There is a differential presentation. The TR beta, it is present in brain and liver. So the brain will sense at brain the thyroid hormone will not be able to act. So brain will sense it as a hypothyroid state, and it will start secreting more and more thyroid. So this thyroid will act on heart and various other places in the body, which will lead to features of hyperthyroidism. So brain will sense a hypothyroid state, and other part of the body will sense a hyperthyroid state. The patient will present with irritability, hyperthermia, and other features of hyperthyroidism. There will be high free T4, free T3, and TSH will be normal. Treatment is observation. We can give beta blockers for thyrotoxic symptoms, and thyromimetics like Triac and TR beta agonist can be used. A very important cause is MCT8 defect. It is also known as X-linked Allen-Herndon-Dudley syndrome. There is defect at the MC8. It is a transporter for thyroid hormone, which takes the thyroid hormone inside the cell, intracytoplasm. In this defect, again, this MCT8 is predominantly present in brain. So patient will have CNS feature. They will have hypotonia. There will be spastic paraplegia. There will be have demyelination, and other part of the body will sense a hyperthyroid state.
So this may not look like hypothyroidism to you. This will present mainly with a neurodevelopmental disorder. So what it tells you is that you should do T3, T4, TSH in scenarios where you're talking about mental retardation.
So, as Sarah discussed, we should screen all patients of developmental delay with thyroid function test. In this scenario, importantly, there will be a high T3, TSH, T4 will be low, and TSH will be mildly high. In some studies, propylthyroxine is used to treat the hyperthyroid state, and LT4 is also used simultaneously. Thyromimetics are useful because thyromimetics use the MCT8 independent axis to cause effect. So they are effective in such scenarios. And since the fetal brain development starts in the fetus period, and in this syndrome, there will be already a brain damage at birth. So we should start fetal treatment.